I appreciate everyone braving the elements this morning. I know it was a little bit challenging for some of you, but appreciate you being here. I will remind you, please silence your cell phones if you have not done so already. And we will start with the roll call. Becky, if you will, please.
Senator Rocky Adams, Senator Berg, Senator Carroll,
Here.
Senator Douglas,
Present.
Senator Herron, Senator Mills, Senator Nemes,
Present.
Senator Rawlings,
Present.
Senator Tishner, Vice Chair Richardson,
Here.
Chairman Meredith.
Present. We do have a quorum and duly constitute to conduct business. We know today's going to be a little bit of a challenge because of the weather situation, and inasmuch I want to deviate from the agenda just slightly, and let's go to the referred administrative regulations. I hope everybody's had a chance to review those. Any questions, comments from committee members? We do have some people signed up to speak on some regulations. If we could, I assume that you're all, well, you are from the same organization, maybe have the same message, but I'd ask Tamara McDaniels, Marlene McKinley, and Morgan Ransdale if you want to come up to the table. And I would encourage you, if you all have the same message, if we can kind of consolidate it, because we got a very full agenda that we need to spend as much time on as possible. But to that end, please identify yourself for the record.
I'm Morgan Ransdell, Board Attorney.
I'm Tamara McDaniel, the Executive Director of the Board of Respiratory Care.
I'm Marlene McKinley, the Board Chair.
And which regulation we'll be speaking to?
The board has 7 regulations before you today. This is basically a substantive housekeeping revision of all of our, where we reviewed and revised all of our administrative regulations, updated all of our material incorporated by reference. And we really don't have any specific overview to provide you unless you'd like it, but we are here to answer any questions you might have.
I appreciate that, but I didn't see any questions from committee members unless some of the late arrivals have been here. Any questions with regard to those? If not, your day is easy.
Thank you.
Excuse. Also, I have a request from Mike Rodman from the Kentucky Board of Medical Licensure. Good morning, sir.
Good morning.
Appreciate you being here.
I'm here. Mike Rodman, the Executive Director of the Board of Medical Licensure. And I just signed up just in case you have any questions.
What a guy. I appreciate
201
that.
KR 9270.
You're endearing yourself to the chairman's heart. I appreciate that. Again, any questions from committee members? There being none, Mike, appreciate you being here this
Thank
morning.
you, sir.
Getting back into, any other comments, questions from committee members? If not, which one was that? All right, we do have one amendment we need to discuss, and I'd ask Mr. Duke if you'll come to the table. This is State Health Plan for Facilities and Services.
Good morning.
Good morning. How are you doing?
Doing well, sir.
Appreciate you being here.
Yes, sir.
If you would speak briefly to this, and then we'll try to act on the motion.
Will do. Yes. Hi. Good morning. Good morning, everyone. Wesley Duke, General Counsel for the Cabinet for Health and Family Services. This is an amendment to the state health plan in regard to the mega voltage requirements. There was a proposal to add a criteria by the Kentucky Hospital Association and during the formation of the plan, and later on there was I think that we received communication and we coordinated with KHA that they felt that amendment was no longer necessary. So we talked to their staff and we have amended it to remove what they proposed, and that's why we're here today.
So it was approved, it was added, now there's being asked to remove it, so.
That's
no
that's a perfect summation.
No one has an objection, I see. So to that end, is there a motion to pass, excuse me? I got them on the script here. Is a motion to adopt the proposed sentence substitute one, no, excuse me. Motion to accept the agency's amendment to 900 KAR 005.020. Motion. Motion from co-chair, second by Senator Berg. All those in favor say aye. Aye. Any opposition? There being none, thank you. Appreciate
Thank you,
this
Senator.
morning. Moving on to our agenda. Again, we're going to deviate a little bit from this and hear Joint Resolution 23. Senator, if you would, please come to the table. I see you have some guests. If you've been before the committee before, if you would identify yourself for the record and feel free to proceed.
Good morning, Senator Shelley Funky Frohmeyer, Senate District 24.
Good morning. My name is Dana Feldman. I work for the Kentucky Department of Agriculture as the Executive Director for the Consumer and Environmental Protection Office.
Good morning. I'm Morgan Bray, the Joint Employee for the Kentucky Hospital Association and the Kentucky Department of Agriculture, implementing the Food is Medicine work.
Appreciate everyone being here, braving the elements. So, Senator, if you would, please proceed.
Yes, Mr. Chairman, we would like to adopt the committee sub.
Is there a motion on the sub? Second. All in favor say aye. Aye. Any opposition? There being none, it's approved. Thank you.
Thank you. This is a priority to us. The House has also filed a resolution, so the need for the committee sub was to reflect and duplicate, actually. I had made some changes believing that there would be a benefit to change some of the words. The House made those adjustments in theirs, but we recognized that there are federal dollars that came from the Big Beautiful Bill that may help support our rural hospitals. So we have a very meaningful portion of this resolution that will allow us to be more likely to pull those dollars down. So I'd like to defer to my partners here on the panel to talk about the excellence and the reasoning behind this resolution. So Morgan?
Thank you, Senator Funky Frohmeyer. I want to start out with the joy that is food is medicine. Since the inception about 2 years ago under the leadership of Commissioner Schell and the Kentucky Hospital Association, we have had such uptake in a positive regard. To date, we have 52 hospitals who have voluntarily onboarded out of the 129 that are currently in the Commonwealth under the Kentucky Hospital Association. With that, we have zero financial implication that hospitals are subscribing to. This is a voluntary basis because they know that patients who are a captive audience who are consuming 3 meals per day with visitors, employees, patient guests are also there to eat. So while we're monitoring the input-output of patients, it makes sense to put a critical lens on what our patients are consuming, all the while supporting local agriculture. So that is the work that we're doing. We are giving autonomy to the hospitals who have onboarded to define what that looks like for them. To date, we have very innovative, creative ways. We have patients whose health is being positively impacted through food as medicine. We're seeing everything positive, which almost seems too good to be true. So I will stop there and pass over to Dana.
Thank you for having us today. Thank you to the Senator for sponsoring this resolution. Commissioner Schell started a Food is Medicine initiative with the Kentucky Hospital Association and his co-chair, Ms. Holly Harris, about May of 2024 with two basic goals. One is to have farmer impact and support farmers and support our rural economies by selecting, having hospitals that are one of the largest buyers of food in the state, selecting local products and local ingredients to serve to patients, serve to visitors, serve to staff. All three of those groups are included. But the other basic function of Food is Medicine is to have healthy inputs leading to healthy outcomes for Kentuckians. So those two premises are what we use here for Food is Medicine. As Morgan said, Morgan and I have been from Owensboro to Pikeville, and we're also in talks with Mayfield. I mean, we've been all across the state together, all different hospitals, St. Elizabeth, ARH, you name it, we've probably been there, had a conversation with someone. We have a meeting with Baptist Hospital in Louisville this week. Everyone wants to be a part of Food as Medicine. They do see the value in it. But what we try to do specifically for each hospital is support and encourage the work that works for them. This is not a one-size-fits-all type of program. It is what works best for that hospital and where they would like to start. Many hospitals are already doing this work. I see Mr. Massey is here. ARH is doing phenomenal work on the Food as Medicine space and is one of the national leaders on Food as Medicine. So we have some exceptional partners. We've had many come on board in the last 6 months or so. I also want to point out that this resolution and the one that will be mirrored in the House is the first of its kind in the nation to declare a state, a Food as Medicine state, and to lay the groundwork for supporting this type of work.
And as we kind of tie up our comments, the rural prosperity, and more importantly, the opportunity for our farmers to better understand what is the demand, they meet the demand. They can grow from seed to harvest rather rapidly, but they need a better understanding of what is the demand. If you can imagine the opportunity to get all of our hospitals consuming Kentucky grown, we truly are amplifying each farmable acre in Kentucky. And that's our objective. Let's help our farmers get back into business more fully in Kentucky. We purchase food from all over the nation, but not nearly enough from Kentucky farmers. So this will amplify the demand that the farmers can supply. So with that, Mr. Chairman, we would appreciate any questions.
Thank you. Very well done. Any questions? Senator Nemes.
Yes, Mr. Chairman, thank you. I have 3 quick questions, if I may. Senator, is this for physical or mental health? And when I buy my chocolate-covered cherry pie, will I need a prescription? And if so, will healthcare cover the cost?
Who wants to take that? Go ahead.
You enjoy that chocolate cherry pie. We know that this is about access. We're not being prescriptive with food unless that is something that a hospital would like to pursue. This is not the absence of anything, but the opportunity for our local growers and opportunity for access. You're welcome.
Senator Herron.
Thank you. And I apologize for my tardiness, but I was listening on my way in. And so thank you for bringing this resolution. I've got a lot of questions, but a big question that I have is on page 2, number 3. It talks about forming public partnerships to support local food systems. Can you talk a little bit more about that piece? Because I know that when we're talking about access, one of the biggest issues is actually brick and mortar. My district is in Louisville. I live in Old Louisville, which is a community that is a very mixed community. You have folks who are living in subsidized housing to millionaires. But when I head home and I try to go to the grocery store, I do not have access to a grocery store in my own community and neighborhood. So can you talk more about the access and what this means as far as brick and mortar grocery stores in communities? Because the issue is that I've seen is that it's not necessarily that people don't want to eat healthy foods, it's that they don't have access to it. So can we talk a little bit deeper about that piece?
Do you want to take that, or do you want me to start? I'll be glad to address a piece of that. So part of the Food as Medicine conversation comes with these opportunities. In addition to sourcing growers who are ready to take on Food as Medicine, the quantity of work, this is also leading to conversations about those produce houses that could be in Kentucky. So this is also leading to job growth, which is exactly what we would have hoped and expected of the Food as Medicine conversation. So if you think of this in a route that we have someone to supply the food, we have an end game of a great quantity of who wants to consume it, naturally we're going to have a need for increased grocery, places to pack, cut, can, freeze facilities, something to do with the seconds produce. And so while there has not been an identified plan for we will put a grocery store here, we are in conversation with several organizations who are excited about this opportunity of an influx of Kentucky produce and protein to be able to be processed here within the Commonwealth.
Just one follow-up, Mr. Chair.
Yes,
I,
please.
I thank you for that. I will do a plug for myself. I do have a bill that would promote access to grocery stores and communities for rural and urban communities. So I look forward to sharing that with you and hopefully working with you all to get that passed this year.
Thank you, Senator.
Thank you.
Thank you, Senator Herron. I also wanted to acknowledge one of the, in our process of building on what is the current supply versus the current demand, we're talking to a group out of Louisville, and they're providing much of what we're serving in the Appalachian Regional Hospital. That's a challenge. That's a long way, as you can imagine. So there's tremendous supply in Louisville. The challenge is there tremendous demand? So it's the chicken or the egg that we're dealing with. And if we're going to continue to advise, guide, train, promote, and develop in our hospitals within Louisville, you can imagine that that may have a larger community impact as well. And I think, like so many businesses, where there is demand, then the suppliers go. But we've got to build the demand. We've gotten away from the meaningful whole foods of fruits, whole foods of vegetables, and we've gone ultra processed, and that's been comfortable. Now we're trying to find another way of actually doing some degree of processing, slicing, dicing, so it's a little easier to prepare, but it's still whole food and it isn't ultra processed. So this is working on both the supply and the demand. Yeah.
Senator Berg.
Thank you, Mr. Chairman. Thank you, women, for the work you've been doing on this. Under the old adage that an ounce of prevention is worth a pound of cure, are we thinking about talking to our schools? Most of our children are fed in schools in this state. And I would think, honestly, that's where you would want to start.
Yes. We also are working on a local first school nutrition program as well from the department. Department of Agriculture also works on farm to school programs and has for multiple years now. So we're very aware of what needs to take place in the schools. And we are working on, it's what Morgan also talked about, we're working on access to more local produce for schools. We're working on trying to create a forward contracting model for food service directors so they can work with a farmer as the farmer is planting for their next season to say, I need this much tomatoes over the course of a year, not just calling that week and saying, I need this much tomatoes, like work in conjunction with each other on what the supply is, what the demand is, and try to get those models started. Right now, it's a little bit off because farmers are making decisions now about what to put into the ground, and schools are buying a lot of their commodity and large quantity products in April. So we're trying to change that model, and we're actually working with some school districts that make large purchases to say, tell me everything you buy, because then we want to know what Kentucky products. We don't expect Kentucky products to provide everything that a school district will need over the course of a school year, but how much can we get in that's local in the door first, and then you go and supplement through your broadline suppliers. So absolutely, we're working on that project as well. And as we move through both projects, we're finding there's a lot of areas where it crosses. So hopefully one will help the other and the other will help the other, and we'll all get both models, institutional feeding models taken care of. Yeah.
It's such a meaningful point that you bring up, Senator Berg. When we puzzled through some of these challenges during our interim MAHA task force, and one of our leaders from the Kentucky Department of Agriculture shared about a 13-inch tall stack of paperwork that you have to go through to procure food for our school systems. And made it to the extent that in order to meet the macros, you almost have to serve ultra-processed food. Well, that's not great. So working through breaking down some of those barriers that led to 13 inches of compliance. So that is well underway and understood. So we are working with the Kentucky Department of Education very closely, trying not to over legislate, because some of this can be handled from a regulatory process. So we don't want to make new laws or create additional stacks of paperwork in the process.
Senator Douglas.
Thank you very much, Mr. Chairman. First of all, I want to thank you, ladies, for bringing this subject into the light. It's been in the dark for a long time. You know, the truth is, if we look at the business models that stores have, they will sell what people buy. Okay, if you think they're looking for your nutrition and all the other things, that's just not really in their business model. They will sell what people buy. You know, most of the reviews now truly suggest that healthy foods are the same cost or a little bit lower than the ultra processed, and yet people still cling to the hope that the ultra processed costs less, and that's why people buy it. It just simply isn't true. Anybody who looks at the data, and part of the problem also is in the hands of local and federal leaders, where statutes actually support the unhealthy foods. And we all know that. It's just sort of the little secret that nobody wants to talk about. So I think we also have to look at some of the home education and some of the responsibilities that we as parents have in terms of educating our children in this space. And these are just things that we need to talk about that nobody wants to talk about. So I just want to thank you all for bringing this into the light, so that at least we can have this discussion and not pretend that we're trying to do the right thing. Thank you, Mr. Chairman.
Thank you.
Senator Douglas, thank you for serving on the Make America Healthy Kentucky Task Force. You were a great addition during the legislative interim, and recognized so boldly that we are attacking physical, mental, emotional wellness with food in a more meaningful way. And the other point that we didn't get to acknowledge, this isn't just fruits and vegetables. This is the protein sources. We grow some beautiful beef, pork, poultry in Kentucky as well. So to be proudly offering that to our students would be wonderful. But of course, to our most sick Kentuckians that are in our acute care settings. So thank you for this opportunity.
Any other questions, comments? If not, I'd entertain a motion.
Motion.
Second.
Motion and a second. All those in favor vote aye. All opposed will vote no. Becky, please call the roll.
Senator Rocky Adams. Senator Byrd. Senator Carroll.
Aye.
Senator Douglas.
Aye.
Senator Herron. Senator Mills.
Aye.
Senator Nemes. Senator Rawlings.
Wholehearted aye.
Senator Richardson.
Aye.
Senator Tishner.
May I explain my vote, please?
Yes, please.
Thank you, Mr. Chair. I apologize for being late. The roads were quite slippery, and I'm very sad that I missed the majority of your presentation, but just reading through it, I think this is one of the most monumental things that we can do to get Kentucky on the right path as far as health and the impacts of that this will have on healthcare in general. So I strongly thank you.
Chairman Meredith.
Aye. The vote is unanimous, and we'll proceed with favorable expression. Congratulations, Senator, on an excellent bill, and we look forward to the next step in this process.
Thank you. Thank you, Mr. Chairman.
Thank you. Our last agenda item for this meeting will be Senate Bill 12, which is my bill. We have presently 7 people signed up to speak on this bill in addition to my presentation, and we will try to accommodate as many people as we possibly can. But just to forewarn folks that we always start this meeting on time and we end on time because we work on very difficult time constraints. With that, I will ask Co-Chair Richardson to assume the chair.
Mr. Chairman, as always, please introduce yourself for the record and then have your guests introduce themselves by name as well.
Thank you, Mr. Chair. I'm Steve Meredith. I'm State Senator of the 5th District of Kentucky.
Rocky Massey with
Microphone.
Rocky Massey with Appalachian Regional Healthcare.
I'm Dr. Cody Reynolds, also with Appalachian Regional Healthcare.
My name is Richard Bartlett. I am the Kentucky State Trauma Program Director, a position that was created by the trauma statute.
My name is Jessica Ambergy. I'm a physician assistant with ARH.
Mr. Chairman, I appreciate the opportunity to present this legislation before this committee today. It's something that I've had an interest in many years. And just looking around this room, I'm not sure anybody has more experience in rural health care than I do. With almost 40 years in this business, and I feel that I know it inside out, unfortunately, and I know the good side, I know the bad side. And we have some significant challenges in rural health care that are probably more pronounced than they have ever been. Speaking specifically to trauma, we passed legislation in 2008 to establish a statewide trauma network. Unfortunately, no money has ever been appropriated to advance this network. As a result, we have a huge dearth of trauma care throughout this state. As an example, we have 20 level 4, which is the lowest level of designation, trauma centers in Kentucky. Our neighbor to the east, West Virginia, which has half the population that we have 34. And I don't know of a statistic that's more representative of the issue that's facing rural health care than the fact that 41% of our population lives in rural Kentucky. Only 17% of our primary care physicians are there. Now, it could be argued, well, we're talking about ER coverage today. Well, you should know that in most rural hospitals, the ER coverage is provided by primary care physicians. As a result, we are 49th in the nation in trauma-related deaths. And it's more pronounced, as usual, in rural Kentucky. And it's the number one killer of our citizens under the age of 45 in our state. Again, more pronounced in rural Kentucky than the rest of our state, principally because our road systems are bad, our quality of life is challenging, and it's just an unacceptable situation. What we're asking today is changing one standard, and that's allow mid-level practitioners to serve as the leader of a trauma, level 4 trauma system. It's the only thing we're changing. And I'll just remind you that this one change does not change the other requirements to be a level 4 trauma center. There's specific protocols that have to be in place, and training has to be in place, equipment has to be in place. So this is the only change. And this change aligns with national standards of the American College of Surgery that recognizes the shortage of physicians throughout the United States. That says having a mid-level practitioner under the direction of a physician is acceptable for level 4 trauma center. This does not change the scope of practice of anyone involved. And it does not change the role of level 4 trauma centers. Level 4 trauma centers are intended to assess the patient, stabilize them, transfer them out, doing what we do within our capabilities. Now, I know that there's been some opposition to this. I'm sure you'll hear about this today, which I have to completely disagree with. You know, the first statement being that if we make this change, then the mid-levels will be solely responsible for level 4 trauma. Well, obviously, people haven't read the bill because that's not what it says. You still have to be under the direction of a physician, either on-site or remotely. And thank goodness for the capabilities we have available to us today that telemedicine can certainly fill that role. Secondly, it says we'll increase the cost of health care, specific to our Medicaid program. You know, we have a real sensitivity to that right now. And I argue that's not the case. We're sending over $40 million a year out of this state for trauma-related care. And just look at the impact upon our locals' economies and the folks in the state, as we're losing about $27,000 a year in lost tax revenue because of our enhanced level of trauma and keeping people from getting back to the workplace quickly. It suggests this will increase liability. I've seen nothing that suggests that. If anything, I think it's just the opposite is true, because if I'm a good plaintiff's attorney and I can get treated in a rural hospital's ER, I think the first question I'm going to ask is, why aren't you a level 4 trauma center? And the answer is quite obvious. The resources just aren't there. This regulation does not say instead of a physician. This is in addition to, and recognizes again the shortage of healthcare professionals throughout this country. And again, aligns it with national standards. It suggests that this will reduce the standard of care. Again, I disagree vehemently, because again, many of our rural hospitals do not have this designation. They provide ER services to the best of their capabilities. They know what their limitations are, but this actually can lift up those hospitals. I gave you a statistic earlier that we only have 20 level 4 in the state. West Virginia has almost double that number. And this not only raises the level of care in those particular ERs, but the hospital as a whole, because it gives training to personnel, protocols in place to handle trauma the way it should be. And lastly, the criticism does not recognize the unique challenges of rural Kentucky. No one's going to convince me today that having no level 4 trauma centers is better than having a level 4 trauma center with a mid-level under direct supervision of a physician. It's just not the case. If it is, then what we're saying is it's better to transport patients than it is to take them to the local ER. There's an expectation with rural communities that the hospital does it all. It's been that way for years. And when folks are looking for an emergency care, they don't take time to say, is this a level 4? Is this a level 3, 2, 1? They don't know what that is. All they know is I'm going to the ER to get my problem taken care of. So I think that's where we have the obligation to provide the highest level of care that we can. And unfortunately, I wish we had board certified ER physicians in every ER throughout Kentucky. But the reality is they're just not there. As a matter of fact, there's a bill that was filed in the House this time to suggest that you got to have a board certified ER physician in your ER. Let's just go ahead and close down all the rural hospitals in Kentucky. Then we won't have to spend time discussing these kind of issues. We're just doing the very best that we possibly can. And this does lift the standard of care for everyone, helps rural hospitals, helps rural communities provide a service that's drastically needed. You don't understand, another uniqueness is the geographic space that we fill. I got some counties that literally, it will take you an hour to drive from one end to the other. And with limited EMTs available to us and ambulance service available to us, sometimes you got to wait an inordinate amount of time to even be picked up. Plus, another opportunity to reduce costs, I'll share with you a personal story. I had a friend that was out running one day and got hit by a car. Another friend called me and said he's been taken to University of Louisville Hospital, stat flighted out. Oh my goodness, he's on his deathbed. So concerned about him. So I keep trying to call family members, trying to find out what his status is. I call his home. He answers. I said, you were stat flighted out with a head injury. What are you doing? They sent me home. Even though there was a hospital quite capable of taking care of the injury that he sustained, we knocked him out. But he was sent to the level 1 trauma center with a $45,000 air ambulance bill that should have never happened. So the most effective care, the most cost-effective care happens at the local level. And our commitment in the rural Kentucky is we're going to take care of our people. Nobody's going to do harm to folks, because what makes rural health care unique is every time a patient comes to us, it's a family member, it's a friend or a friend of a friend. We know these people. We're going to make sure they get the best level of care that's possible. And this helps us expand this level 4 network, does not compromise care, makes it consistent with national standards. It's something that desperately needs to be done to reduce this. Let's quit being 49th and 50th. I speak of it from a very broad perspective. I'm going to let these individuals talk about it in their individual communities, but I will tell you this again, suggesting that no level 4 is better than a level 4 with a mid-level under direct supervision of a physician, that's an irresponsible position. My father, I'd give anything in the world if he had died in a hospital rather than in a helicopter. That's what we deal with in rural Kentucky. But with that, I'll let my guest speak to this bill. Thank you.
Thank you, Senator Meredith. And I, like Senator Meredith, has spent 44 years in rural health care in eastern Kentucky and southern West Virginia. We've got some other ER docs here with us today that help staff our ARH hospitals in support of Senate Bill 12 as well. Our ER docs functioning where in rural Appalachia, they're not afforded the vast medical resources that their colleagues are in the more populated areas. There's no anesthesia, there's no vascular surgery, no critical care specialist. They have to have a team. They have to have a team of folks. And it's a team of folks that have to be validated at the top of their game. The guidelines set forth by the American College of Surgeons validates that top of the game. The X-ray department, the laboratory, the cardiopulmonary department, the credentialing, the competency, the timeliness of care, all those things are validated by the American College of Surgeons as a level 4 trauma facility, which, by the way, includes a qualified mid-level provider supervised by a physician, which is exactly what Senate Bill 12 says. So that's how we have all the aspects come together to ensure quality outcomes for in these rural settings, and all of our team there at the top of their game, and that's kind of ER that I want to go to.
Thanks, Rocky. Good morning. I really appreciate the opportunity to speak in front of you again. My name's Cody Reynolds. I grew up in Phelps, Kentucky, about 700 people. Grew up around EMS. My mom ran the EMS service in Phelps for about 25 years. I'm a board-certified emergency medicine. I'm a fellow of the American Academy of Emergency Medicine, and I'm the only board-certified emergency medicine that works more than 10 shifts within the entire ARH community. The only board-certified physician that works real full-time, one. Level 4 trauma centers are often the only point of access for injured patients in rural medically underserved communities. These hospitals are responsible for the initial stabilization, and we offer safe transfer. But Kentucky's current physician-only requirement makes it so difficult for rural hospitals to maintain or even achieve, level 4 trauma designation, even when they meet the national trauma quality standards. We're facing a real emergency physician workforce problem. Just some points here that I wanted to bring out. That national data show that rural counties are far less likely to have emergency physicians than urban areas, and over 40% of U.S. counties have no emergency physicians that are reflected in their Medicare billing at all. And even more concerning is some of the trends in emergency medicine over board-certified physicians in the last couple of years. 96% of recent emergency medicine graduates are practicing in non-rural settings. So 4% across the country of board-certified emergency medicines are willing to take on the task of caring for rural people. The pipeline is not replenishing the emergency care, especially in rural emergency care. SB 12 aligns with Kentucky with nationally recognized standards from the American College of Surgeons and the American College of Emergency Physicians. It allows advanced practitioner providers to function with a physician-led real-time supervision model, a model that's already safely used across much of the country. This is not a scope creep. This is when Jessica Ambergy or Brent Newsom or Billy Hedrick are working in Our Lady of the Way or Mary Breck. I'm available 24/7, 365. I don't go off call. If they need me, I answer their call, whatever it is. And I have colleagues that are similar. We don't let them down. They don't let us down, and we don't let our people down. For rural hospitals, this alignment is transformational. It allows us to maintain trauma readiness, keeping emergency departments open, and stabilizing our patients, our family, our people locally, instead of losing this trauma designation due to staffing realities that are obviously out of anyone's control. This matters even more and more as emergency medicine residency applicants have fell sharply in the last 5 years. There was a significant increase in unfilled positions, which was not a thing at all when I was going through the match. There is a real and present workforce issue here, and it disproportionately affects rural America, especially rural emergency medicine. Just to kind of, off the top of my head, Tennessee, West Virginia, Ohio, they all have trauma standards that focus on system readiness and protocols and physician oversight, not physician-only bedside presence. That's 3 neighboring states that are operating trauma systems without these rigid physician-only languages at these lower trauma levels, while maintaining completely physician leadership and quality oversight. It doesn't stop at rural hospitals. That's the thing that I want everyone to really kind of key in and understand. When rural trauma centers lose designation or they don't get designation, patients bypass them, like Senator Meredith alluded to. We flood urban emergency departments. That leads to longer transfer times, increased crowding, strain on an already stretched trauma system that was obvious and clear that we were facing in Kentucky. It is obvious. If you've been in the middle of a trauma at 2 o'clock in the morning in South Williamson, Kentucky, trying to get someone cared for and trying to get them to a trauma center, it's not that easy. It's not as easy as it seems. And even when you have acceptance, where's EMS? It's not there. Preserving these rural level 4 access allows appropriate stabilization and triage and care, and it improves outcomes, and it keeps people from dying. It doesn't lower standards. It doesn't remove physician oversight. It does not. These trauma designations remain a rigorous quality framework. This bill aligns with Kentucky with national standards and regional practice in a way that's transformational for rural emergency medicine and rural trauma care. It allows us to invest confidently and preserve access and what we should have done in 2008 and strengthen Kentucky's entire trauma system.
Dr. Reynolds,
Sure.
if I could just interrupt.
Absolutely.
Just as a reminder, we've got 15 minutes left. We have 3 senators with questions, and we
I'm
have
done.
7 signed up to speak. So we do need some time management here, if at all possible.
Absolutely.
Do we have any more comments, Mr. Chairman?
Do have 2 additional guests. I think the doctor did an excellent job of surmising the situation. I think perhaps Mr. Bartlett, since he's been in charge of the trauma network for 20-plus years, we certainly would like an opportunity to give him a minute or so.
Let's just be mindful of time and questions from the committee, and then also those signed up.
Thank you. I just want to point out that this gentleman actually was the administrator of a level 4 trauma center. So he's got a lot of solid background as to why this bill was important, and I appreciate what he's done here. Secondly, if for those who are not clear about what is a various type of trauma center, on the Kentucky Hospital Association website, kyha.com, in our trauma focus area, I do have a document from the American Trauma Society that actually talks about each of the 4, and actually in some cases there's a 5th level of trauma centers, so you get an idea of what makes up a trauma center. And a level 4 is basically different from a regular ED. It's structured, they've got protocols in place, they practice, they have standards in terms of their staff and what they've got to have. They practice it. I mean, I've even seen some where they've actually got a drawing in the trauma room of how the staff is to stand around and what their roles are. It's very impressive what they do. And in terms of cost, I want you to know that the CMS does have a trauma activation charge profile that's available if they are, 1, a designated trauma center, and secondly, they've got to have activation from the EMS system on the way in. So if EMS calls and says, hey, ER, we are en route with a full body crunch from a motor vehicle accident, they'll call their team in. They'll bring them in, stand them up, they're ready to go when they walk in the door. That's what's different from a trauma center versus a regular ED. So that's important. I was there when I helped to write the regulations and the statutes, so I have some history about this, and I go visit these facilities on a regular basis. We actually are growing our trauma system. I have recently done trauma verification site visits at the TJ Health System. They're bringing 2 more online. We've just given the go-ahead to give them some designation. Med Center Health is looking to bring on 5 in South Central Kentucky. I have just recently come back from a verification visit at Baptist Corbin. They're going to wind up getting a level 4 designation. And in another week, I will be listening in and participating with the American College of Surgeons on a verification visit at the CHI St. Joseph's London facility. They're going for a level 3. So our system is growing. But I've also visited recently with some of the ARH folks, and they are looking to grow their system as well. And their use of the APP is critical for them. And I want to point out, and I'm going to leave a few minutes for this superstar over here, what's different about the ARH system over what I've seen in some of the others is they've actually created some excellent guidelines. They don't just turn these folks loose. They're vetted. They have to prove themselves before they are given the right to do this lead in an ED as the trauma lead over there. And I think they do a great job at that. Give you a few minutes.
Okay. Thank you. So I just want to reiterate a couple of points here. Number 1 is the physician supervision. It is physician-led. We have a list of backup physicians that are available. They are available via telehealth for the entire shift, but also available to turn up in person within the facility's bylaws with a reasonable response time. And depending on the facility, 30 to 45 minutes on-site time, depending on how remote the facility is. And then number 2, scope of practice. We have providers that have been practicing within this model since 2018. There's going to be no change to the scope of practice. It's just going to give us a designation and standardization to improve our care. All of these providers are career emergency medicine, and they carry the same certifications as the physicians that are working in these roles.
Mr. Chair, we would entertain questions.
We have 3, and I would remind the senators, please keep it short and sweet. Probably not a lot of time for follow-ups at all. That means no follow-ups. Senator Berg, please.
Thank you for allowing my question. Thank you for bringing this bill. I really honestly think I have a good understanding of both sides of this issue. I do have a statement, and then I do have a question. I have 2 statements.
Quickly,
One,
please.
direct supervision. Everybody keeps talking about we would have mid-level practitioners under direct supervision. Direct supervision in medicine means that the physician is on site and can respond immediately. I mean, I went through the federal system with the definition of what it means to be a direct supervisor. Because, guys, we had problems. We had an elected person in this state who was practicing medicine who said that he was directly supervising residents in the OR when he was actually here in Frankfurt. That is not direct supervision. And I mean, in the federal system, in the VA system, you can't even go grab a cup of coffee. You have to be that close.
Senator Berg, please get to the question if you have a question.
We are, I think, confusing board-certified emergency physicians, which, I mean, in a perfect world, every ER would have a board-certified emergency physician. We're not asking for that. We are asking for an actual licensed MD to be available. Now, if you have a 30-minute response time, but that's not what this legislation says, guys. So are we talking about a 30-minute response time here, or are we talking about somebody who is remote and not available for hands-on work?
I guess that's the the definition of what you feel like direct supervision is. Whether or not it would be to be there to lay hands on a patient versus to give direct orders and to be able to walk them through how to to get themselves out of a situation that they feel like they need help with. And to your point, I mean, to have a physician in the emergency department at all times, in a perfect world, yeah, that it should be that. But I would argue that many of my APP counterparts are equal to many physicians that aren't board certified emergency physicians in terms of quality emergency care. You know, MD beside your name, or in my case, DO. It's, you know, after a few years, these people are absolutely on par.
Thank you so much. Senator Carroll.
Thank you, Mr. Chairman. Thank you for the presentation. If with liability issues, if there is an increased liability on both the doctor and the nurse practitioner, talk about that and talk about doctors' willingness to do this if there is an increased liability.
Liability is mitigated by capability. We ensure all of these providers have hands-on procedure courses. They have the same certifications. They can stabilize trauma patients. And we do have 2 of our routine backup physicians here today to support us. We've been practicing this model, like I said, since 2018, and they are available telehealth, and we do alternate physicians, so they are available to respond in person as well to do any direct care that may be required.
This law will.
Thank you so
And
much.
just
Go ahead.
quickly, I probably would have been more comfortable if the language stated if a doctor was not available to do this, rather than or make it that the first priority is to have a doctor. If the hospital can't get those doctors, then a nurse practitioner. I could see possibly some hospitals using a nurse practitioner when a doctor is available to save money. And maybe I'm wrong, correct me if I am, but that was the thought that came to mind.
That's not the motivation for this bill.
And I'm not saying it is, Senator, at all. That's just a consideration.
And I think it's an argument some folks will present, but the reality is if they can't adhere to the standards, they lose their designation as a level 4 center. So they understand the commitment that has to be made with physician supervision. And as this doctor said, you know, he's available 24 hours a day, 365 days a year, but he has backup as well. So you have to have that coverage in place.
Okay, thank you, Mr. Chairman.
Thank you. Senator Herron.
Thank you, Mr. Chair. And Senator Byrd kind of asked this question, but I'm not a physician and don't have a lot of that knowledge. Can you talk a little bit more about currently what is direct supervision? Like what happens now today with that supervision, and what will happen if this bill was to pass, just so we can understand exactly what that means?
If this bill passes, it will allow us to standardize and become part of the trauma work network and elevate the care that we provide by following metrics. But in terms of on the ground, we're currently practicing at this model. We have 3 hospitals that practice with advanced practice providers that have been career emergency medicine with offsite physician backup.
Well, what I'm asking for is, like, currently, if we say direct supervision, like what does that look like in practice? Is there somebody physically there? Is it not? Just like make it super plain about what that means in everyday practice.
Yeah. So currently, as Jessica said, like there's an advanced practice, you know, practitioner that's in the emergency department 24/7. There is typically not a physician in house at that time. And that doesn't change with the designation. It will still be the same sort of supervision that we already have in place. So if that answers your question. That doesn't change as far as there are mid-levels that are staffing the emergency department, and we're on backup either to be called to have a telemedicine visit or to come into the hospital. That would still be the exact same. Good.
Thank you so much.
Doesn't say that.
We're down to if you guys could step back, and we'll go ahead and try to do something here. We've got 6 people signed up, but we've got 2 groups represented, the ACEP and the KACEP. If at all possible, if someone from each group could designate someone real quick, because I want you to be able to comment, but we are less than 5 minutes. There's another committee starting at 9 o'clock. So if you, 2 minutes each, if you could each identify, are you both representing these 2 different groups? Okay, wonderful. Thank you so much for allowing for that. 2 minutes each. Please identify yourselves. Make sure the green light on the microphone is on. Identify yourselves and 2 minutes, please.
My name is Patrick Grace. I'm an emergency physician in Kentucky and on the board of the Kentucky College of Emergency Physicians.
My name is Dr. Daniel Moore. I am also a board certified emergency physician representing American College of Emergency Physicians and my emergency medicine group, Thoroughbred Emergency Physicians.
Mr. Chair and members of the committee, as I said, my name is Patrick Grace. I'm a native of Bowling Green, Kentucky, graduate of Greenwood High School, studied at the University of Kentucky College of Medicine, and after years of specialty training in emergency medicine, I'm proud to say I'm a board certified emergency physician who has practiced at many different facilities throughout Kentucky. I actually feel so strongly about this legislation. I was in professional development in California and flew back last night so that way I could be here this morning and speak on this. I'm here today on behalf of the Kentucky College of Emergency Physicians Board of Directors to speak in opposition of the proposed language that permits off-site physician supervision of a nurse practitioner or PA in the emergency department. I'm here representing the interests of patients and communities. My views are my own and KSEP's. They do not represent the views of the University of Kentucky. I'm sympathetic to the difficulties in funding rural health care. However, I do not believe that because someone lives in Harlan or Mayfield or Middlesboro or any other community in Kentucky, that they should not have access to a physician in their emergency department, the same as someone in Louisville or Lexington. Emergency departments are fundamentally different from other aspects of our health system. They don't arrive with diagnoses. They don't come with appointments. They come in critically ill. They come in injured. Decisions have to be made within minutes to determine whether they live, die, or suffer permanent disability. The only people with the training to be able to do this in the most critical settings are physicians. Senate Bill 12 codifies the practice of emergency medicine in emergency departments functioning without a physician physically present, relying on off-site supervision. And when seconds matter, remote supervision is no supervision. Kentucky patients deserve physician-led care at the bedside. And nurse practitioners and physician assistants, they are essential and valued parts of our team. I practice with them myself. We work side by side in our emergency departments. The difference is not dedication, it's not commitment, but it is depth and training and scope of practice, which is why numerous medical organizations advocate for a physician-led team. While some may argue that on-site physician availability for trauma centers is restrictive to rural hospitals, I just want to point out that many of our neighbors, including Indiana, Virginia, and South Carolina, have passed legislation requiring a physician be physically present in all of their emergency departments. They have had no rural hospitals that have closed because of this legislation, and that is not our goal by being here today and opposing this language. I'll let Dr. Moore speak next.
Yeah, so honestly, there are lives at stake here right now, and asking us to respond in 4 minutes is difficult. So I'm a board-certified emergency physician. I've got 15 years of emergency medicine experience, including 12 years at a level 1 trauma center, 3 years at University of Alabama, 9 years at UK. I recently, in the last few years, transitioned into rural emergency medicine practice. I'll tell you why in a minute. My career has included clinical care, administrative leadership, education, operational department oversight. I'm a nationally recognized leader in emergency medicine quality and operational and performance. There are a few people in this state who've poured more into the improvement of our health care and emergency medicine than I have in my career, including process improvements that I did at the University of Kentucky that created capacity for hundreds of thousands of extra patients to be transferred to our site, which, by the way, University of Kentucky is the #1 transfer receiving hospital in the country. I've trained emergency medicine residents, advanced practice providers, and medical students. I'm keenly aware of the differences in training, their scope of practice, and clinical readiness for emergencies. I want to point out, too, that level 4 trauma centers are emergency departments. Trauma is a very small part of what we take care of in emergency departments. I don't want you to forget that there are children coming through, that there are medical emergencies, that there are primary care problems. The scope is far beyond that of just trauma. So when we're talking about a level 4 trauma center and we're asking that there is a a advanced practice provider or physician assistant in those sites without direct physician oversight. This encompasses all of emergency medicine, not just trauma. I was born and raised in Frankfort, Kentucky. I still live here. Personally not from Appalachia, but my wife's family is from Appalachia. Dr. Ryan Stanton, close friend of mine, we actually have in the state of Kentucky the president-elect of the biggest emergency medicine group in the world, American College of Emergency Physicians. And he is from East Tennessee, from Appalachia, and he very much aligns with our statements here. We agree and we align that there is a problem with emergency medicine delivery of care in the state of Kentucky, but this is not the solution to that answer or to that problem. And we deeply want to fix some of these problems. And in fact, in my career, I've stepped out to create a rural emergency medicine practice to address this. Emergency medicine is best practiced by physicians, specifically board certified emergency physicians. I ask all of you in this room, when you have your emergency, who do you want taking care of you in an emergency department? The House bill that was discussed, the language currently does state board certified emergency physicians. That is not the intention of American College of Emergency Physicians. That is in committee, I'm told, and that language will change to physicians. We do want to eventually get to the point where all emergency departments have board certified emergency physicians, but that is not practical today. We agree with that. And the response to rural healthcare challenges should not be the reduction in training requirements or to lower the standard of care. I want you all to know that the ATLS course, this requirement, is a 2-day course. Our requirements to get to where we are, I was almost 30 years old by the time I got to the point where I was capable of taking care of real trauma. And don't forget that pediatric emergency medicine emergencies, major trauma, airway crisis, surgical emergencies occur in every part of Kentucky. The response to rural, in community and rural emergency departments, I personally managed pediatric cardiac arrests, critical care resuscitations, massive hemorrhages, traumatic and medical emergencies such as esophageal varices. You don't have 30 minutes in these situations. These are momentary interventions that need immediate intervention from a skilled provider, otherwise someone will die.
Dr. Moore?
Yes.
I'm sorry.
Yes.
But we need to move on. We are over the time that our committee has allowed, and we still have to cast a vote on the bill.
Okay.
Senator Meredith, before I give you a chance for any summary, I'm going to go ahead and ask if there's a motion.
Can I say one more thing? Just real quickly? Just like one sentence.
One sentence.
I own and operate an emergency medicine group that staffs a level 4 trauma center. We have 100% board certified ER doctors in our group. It can be done, and it has been done. That's it.
Thank you. Do I have a motion on the bill? I have a motion and I have a second. Senator Merritt, do you need a summary? If you two doctors could step back, please, we'll have Senator Merritt, the sponsor of the bill, offer a summary, and we'll move to a vote.
Very brief, Mr. Chairman. I want to read to you a policy statement from the American College of Emergency Physicians that says they acknowledge that there are currently workforce limitations in specific CMS designated facility types, meaning critical access hospitals, small hospitals, in which supervision of a PA or NP by an emergency physician may be provided off-site by telehealth means as follows. So we can't say we recognize this issue, but we're not going to do anything about it. This gives us an opportunity to it won't fix the problem, but certainly improves the current situation that we have. But again, if the American College of Emergency Physicians passes a policy statement, then there's got to be some substance to it. And again, it enhances the quality of care in rural Kentucky. That's all I have, Mr. Chair.
Thank you. We have a motion. We have a second. If we could call for roll call vote, please.
Senator Rocky Adams.
Can I explain my I vote?
Yes.
Okay. I thought I knew how I was going to vote on this issue before I came in, and the testimony has been very compelling, and I can really see both sides of this issue. On one hand, we have such a workforce deficit in these rural areas that this seems like an absolute no-brainer. And then on the other hand, we want to make sure that we have an outstanding level of care. I'm going to be a yes vote to move this forward, but I'm also interested to continue hearing from those that are involved on this issue to make sure that the final product is what we want the final product to be. So with that, I'm an aye vote.
Senator Berg.
Explain my no vote. I would be much more likely to vote aye if this legislation actually clarified for me what type of supervision we're talking about. But if you're talking about off-site supervision, where there is no, and I'm not talking about a board-certified emergency physician, where there is no trained medical doctor whatsoever who can respond. And I know right now the hospitals are using a 30-minute, a 45-minute. There's nothing in this legislation that requires that. There is nothing here that seems to me to require that you have access to an MD. That scares me. I would rather us fix that than lower the standards.
Senator Carroll.
I'd like to pass an aye vote and explain my vote. The balance on this, it's very difficult. On basic care in emergency room where it's not immediate, where there is time to consult with the doctor, not so concerned about that. At the point where someone comes in and it is a urgent trauma situation where decisions are being made on the spot, that concerns me. But the alternative to that is possibly transporting the patient 30 minutes, an hour with very minimal care. So it's a lesser of two evils for this situation. And still have some questions to ask, but for now, an aye, Mr. Chairman.
Senator Douglas.
I'm going to pass, but I really want to explain that vote as well. I think we're all going to probably want to take a look at some of those. You know, one of the things that we're talking about here is this doesn't change the level of care, and that's not an argument that we have here. I did emergency room work for 4 years. I get it. I get the late nights. I get the patients coming in, and you have absolutely positively no idea what's going to walk through that door. You know, I hear a lot about board certification. Board certification is a test. It's not required to practice medicine here in the Commonwealth of Kentucky. So why don't we stop all the academic gyrations trying to suggest that board certification means that you're a better physician than the others? Because I'm here to tell you, you're not. You're not. You've simply passed the test, and you can talk about that. My real concern is whether we're taking a designation, and I know this is not the intent, but taking a designation and saying if we change that designation, then we can get more reimbursement, and that'll help keep our rural areas open. That is one way to do it, but I'm not sure if that's the best way to do it. So, Mr. Chairman, I just have some pause. I don't want to kill the bill right here. I do think it would benefit some of our other senators to have a crack at this nut. But I understand the emergency room, and for those of you all who have not been at the tip of the spear in the emergency room, you don't know what you're talking about. You don't until they walk through the door. Thank you, Mr. Chairman.
Senator Herron.
No.
Senator Mills. Senator Nemes.
Aye.
Senator Rawlings.
I'm going to pass as well.
Senator Richardson.
Aye.
Senator Tishner.
Explain my no vote, please. I appreciate your work, Senator Meredith, on this, and I absolutely understand what you're coming at. I feel like this is a fairly significant change to be implementing, and it gives me pause. I've had quite a few people reach out from my district who are concerned about this legislation, and I would like to just take more time and have some more discussions about that with you. Thank you.
Chair Meredith.
Display my aye vote, Mr. Chair. Been in this august body for my 9th session. And my mission since I've been here is to improve the quality of life of rural Kentucky. And the basis of that has to be health care. And I can share with you horror story after horror story about how the system's collapsing. I can fix this quickly. You give payment parity to rural communities for healthcare services that we get for the urban areas, I can fix it tomorrow. But we're not willing to do that for a multitude of reasons. But quite truthfully, I'm worn out. I'm tired of fighting the fight to ensure that rural people in Kentucky have a quality of life that's comparable to their urban counterparts when we don't devote the resources to it. If you really want to fix this problem, what we focus is on the poverty in rural Kentucky. Start making a disproportionate investment in rural Kentucky to create jobs, lift people up, lift the quality of life, lift their salaries, on and on and on. I'm tired of the fight. This is a simple bill. Changes one thing that can truly make a difference in rural Kentucky, and the hesitancy on this beyond me. And I'll go back to the statement again from the American College of Emergency Physicians, doctor, about oversight. It says, acknowledges there are currently workforce limitations to which supervision of a PA or NP by emergency physicians may be provided off-site by telemedicine. So if your colleagues are saying that, I don't understand why that's not acceptable, particularly this day and time where we made the investment in broadband. We're actually providing patient care via telehealth, but this oversight in this example is not successful. Plus, you heard testimony from a physician who says, I'm available 365 days a year, 24 hours a day. That's the kind of commitment we should reward rather than punish. Thank you, Mr. Chair.
Thank you. Motion passes 6-2 with a 6-3-2 favorable expression. If there's no other business, we are. Thank you. Our next meeting will be next Wednesday, 8 a.m., January 28th.
Yeah, I know you are.
Hi, my name is Juliet. I'm one of the local news reporters.
Oh, nice to meet you.
Nice to meet you. Do you have like 2 shakes to like tell me just like a little bit about it? Okay, cool.
Hey, how are you?
Hey,
Cody, nice to meet you.
Yeah, nice to meet you too. What type of supervision